Hello, this is Matejka sharing with you my final project, Muscle Energy Techniques Compared to Patient-Performed Mobility Exercises for Sacroiliac Pain and Dysfunction. Sacroiliac joint pain and dysfunction actually accounts for about 30% of patients with low back pain. So 30% of patients that do present with low back pain, we can attribute it to SI dysfunction. So it's a very large chunk of patients there. SI joint pain is also caused by a variety of biomechanical forces: hypomobility, hypermobility, malalignment, fixation, subluxation. For this study, we'll be talking about sacroiliac dysfunction as hypomobility, so decreased mobility in this joint. So my two treatment options I want to compare are patient-performed mobility exercises versus muscle energy techniques that are performed by a clinician. My research question will be, in patients with chronic sacroiliac pain, are muscle energy techniques more effective than patient-performed mobility exercises in reducing pain and increasing function? So my two outcome variables are going to be reducing pain and increasing function. My study design is going to be a point-of-care randomized trial. I'm going to have two treatment groups. Group 1, again, the patient-performed mobility exercises, and the second group will be the muscle energy techniques performed by a clinician. Subjects in each group will receive 7 days of treatment, and I'm looking to target the population of college athletes aged 18 to 24 years old. Some of the inclusion criteria: patients that report chronic low back pain for more than 2 weeks. They must be on a sport roster at our university. Pain over the sacroiliac joint. And then this one's really important: sacroiliac dysfunction or pain attributed to hypomobility. So again, there are a variety of causes for SI dysfunction, but I'm just going to be concentrating on hypomobility. And then subjects who also have a positive result in 3 out of 4 pain provocation tests, which we'll discuss later. Some of the exclusion criteria: I'm going to rule out subjects that have had acute injury of fracture to the lumbar pelvic area, any pregnant subjects, anyone with abnormal neurological signs such as abnormal sensation or deep tendon reflexes, any other long-standing spine diseases, spondylolisthesis, stenosis, disc disease, etc., hip joint pathology, a history of a major surgery of the spine, a true leg length discrepancy. I will be admitting subjects who have apparent leg length discrepancy. And then again, hypermobility of the SI joint. We're going to want to rule them out since we're only focusing on hypomobility. So in order to determine which patients are truly suffering from hypomobility, we need to do a physical exam. And this will include an iliosacral exam, looking at the ASIS locations, PSIS locations, noting if the leg length discrepancy, if there is one, and ruling in only apparent leg length discrepancies, not true leg length discrepancies. Along with the exam, I'm going to perform 4 pain provocation tests. The 4 I've selected are Gainsland's, Patrick's or Faber's, a posterior hip thrust test, and SI compression distraction tests for ruling in that the patient isn't just suffering from low back pain, that it is specific to the SI joint. So to measure my outcome variables, again, I have 2, looking at reducing pain and increasing function. I will be using the visual analog scale, which is pictured here. The patients can physically mark where they feel that their pain is. And I'll also be looking to use the Esterly Low Back Pain Disability questionnaire. Again, having the patients self-assess their disability or functionality. And this is just a series of Likert type questions that assess different areas of life. So daily activities such as in the home, physical activity, lifting, etc. So that will be used to assess disability. To measure my success in each treatment, I'm looking again to decrease the number of positive pain provocation tests. So those 4 tests, originally they were admitted if they had 3 out of 4 positive. We're looking to decrease that number. Decrease pain according to the visual analog scale. Decreasing disability scores based on the questionnaire. And decreasing any leg length discrepancy, assuming that they had one when they were admitted to the study. So to implement this, some of the challenges I foresee, subject recruitment numbers. I am at a small university, and that's why I decided to keep my study as a point of care trial. That way I can keep admitting more subjects as cases of hypomobility present themselves. I also don't have a true electronic database for collection of this data, so I would have to do the visual analog scale and the questionnaire on paper pencil and then transfer everything. But I think there are a lot of benefits from this as well. This study gives the opportunity to collect data from both clinical examination and the patient perspective, so I think that's very important. And I think a big benefit, for our university and myself is the possibility of creating a clinical pathway for the treatment of SI dysfunction. So hopefully that will be a benefit from this study. Some of the stakeholders I thought about for this would be the providers, in this case being athletic trainers, patients being student athletes, and policymakers. Again, I would like to develop a clinical pathway for SI joint dysfunction treatment, and that would be working with our student health center as well. So for the providers, we're always trying to use evidence-based medicine. And again, since we're collecting information from both the clinician and the patient, this really is going to give us the best research evidence because we're combining clinical expertise with our patient values to make clinical decisions. And again, hopefully based off of this, it would give us more information on which treatment option, patient performed mobility exercises or muscle energy techniques have a better outcome for our patients. So the patients being our student athletes, they're going to have the opportunity to give feedback, give their perspective on their treatment, whichever one they're receiving, which overall is going to improve their quality of care. Again, the policymakers, I foresee us working closely with our nurse practitioner, possibly the other folks there at the health center, for, again, creating a clinical pathway. I think, especially since we're gathering both clinical and patient information, we'll be able to understand, what type of pain or what type of dysfunction patients would have at a certain point in their treatment. I think this could also lead to an SI assessment policy. Are we always going to use those 4 pain provocation tests that we can use for every case of SI? That will probably lead to more accurate diagnosis and, again, better treatment selection for our patients. I think this could have a big impact on athletic training. Again, more accurate assessment and diagnosis. We know that we treat a lot of student athletes and patients with low back pain, but being precise, being accurate with our assessment and diagnosis, again, is going to help the patient since we're treating a very specific condition. Since we are comparing 2 treatment options, 2 different treatment options, it's going to give us more of a variety with our treatment selections. I think we can have a better understanding of muscle energy techniques, how they work. We don't need to be afraid of them. We can use them in our clinical practice. And again, bottom line, providing a better quality of care for our student athletes since we are being more accurate and we are getting better diagnoses and then having better treatment options available.